Good afternoon, everyone, and thank you for attending this session of Grand Rounds. I'd like to welcome our presenter for today, Dr. Julia Frith, who will be presenting on the importance of travel screening. At this time, I'm going to stop sharing my screen and turn the presentation over to Julia.
All right. Hello. Can everybody hear me okay?
We can hear and see you.
Fantastic. All right. So what I wanted to talk about today for the next 30 minutes or so is about the importance of a travel screen. So really the question being, why do a travel screen? So when we think about the idea of a travel screen, this is not a new idea that has come to us or a new process that has been developed, right? I know that we all started to really think about our travel screen processes during the COVID pandemic, and that's probably when most people thought of the idea of the travel screen. But we know that the travel screen process has been recommended for a long time prior to that, including during the time frame of the West African Ebola outbreak and prior to that as well. So why do we want to do a travel screen? What makes the travel screen so important? Interestingly, as many as 43 to 79% of travelers that travel to low and middle income countries become ill with a travel associated health problem. Now, not all of those problems or those health issues show up right away, and the incubation periods of these illnesses may vary. Usually they present within the first month, but it could take up to years for the infection or the illness to present itself after the initial infection or travel, thinking of things such as tuberculosis. Doing the travel screen or having an effective travel screen is important because it allows for the providers to approach the differential diagnosis with the patient presentation and risk factors related to travel considered. So for example, what was the destination? How long were they there? Did they know they have known exposures? And having that information can change some things that are simple presentations or common presentations to our emergency department and providers, and take that information and change the diagnosis in those scenarios. So I put in a couple of case scenarios for us to look at in relation to this question of why a travel screen. So an individual shows up in the emergency department. They are triaged. They are not acutely ill. Their symptoms include fever, vomiting, and rash, and their differential diagnosis includes viral illness or a tick-borne illness. When the provider sees this individual, they do a respiratory pathogen panel and collect other important pertinent labs on this patient. The patient ultimately sits in the emergency department for about 45 minutes before being brought back to a room and placed in any type of precaution. Interestingly, they realize that this person does have a travel history. Specifically, they went to Equatorial Guinea. And so while this could be malaria, it could also be a viral hemorrhagic fever. The Marburg outbreak in Equatorial Guinea is currently occurring with an alert level 2 for travel. And this would absolutely have the potential to change things that are done from both a patient care perspective, but also an infection prevention perspective. In this scenario, we have potential exposures in the waiting room, staff exposure related to lab collection, the question of can we continue to use the lab equipment? And from a patient care perspective, are we treating this patient for the correct illness? Specifically, did we start fluid replacement on this patient? Have we started contacting treatment facilities to understand what needs to be done? This picture here was pulled as a recommendation from the CDC site on what the Marburg rash would look like. So clearly not that much different than other rashes that we may see come in through the emergency department, but processes that we put in place for both the care of the patient and what we would do from an infection prevention perspective would be drastically changed depending upon what this travel screen process looks like. A second case scenario, you have a pediatric patient a child that shows up to the emergency department with fever and sore throat. In this scenario, the travel screen was completed, but the country was not noted. This individual waited in the emergency department for 2 hours prior to provider assessment that included a differential of mono and strep throat. Tests were ordered in this scenario as well, and the treatment for strep was actually also started. The patient ultimately had traveled to Nigeria to visit family who also had become ill and just returned 3 days prior to symptom onset. In current state, there is a diphtheria outbreak in Nigeria with an alert level 2 for travel. While it could be strep, which would probably be the primary infection that one would think, particularly with the increase in strep in our community at this point, diphtheria is also an opportunity of an infection process that could be on the table in this scenario. Another potential case scenario would be a person that shows up into the emergency department with headache, nausea, vomiting, a stiff neck on exam, has an abnormal lung puncture. They're admitted and for potential meningitis, though unclear if it is viral or bacterial, and a travel screen is not completed on this patient. Ultimately, it was discovered through post-mortem exams that the patient traveled to Mexico 28 days prior to having a surgical procedure done where they had an epidural specifically prior to liposuction. And there is the fungal outbreak occurring current state following surgical procedures in Mexico with a level 2 travel advisory. While none of these scenarios are real life scenarios, at least to my knowledge, not pulling from personal experience, they are scenarios that patients present with these types of non-specific infection or presentation symptoms to our emergency departments all the time. And if we do not ask those critical questions of, did you travel someplace? There is the opportunity that we may not treat the patient with what needs to be treated, and we may expose large number of people to particular pathogens of concern because they've not been isolated and identified quickly and promptly. So the question becomes, who do we screen? So interestingly, there was an analysis completed at Massachusetts General Hospital, and the general travel screen was completed for 77% of all Massachusetts General Emergency Department patient encounters. However, only 16% of the encounters with reported foreign travel had a documentation of the country to which they traveled. And so we knew, or they knew, that the patient had traveled outside of the continental United States, but they did not know where exactly they had gone and what other country they had been to. And this is obviously very important because it could impact the diagnosis for your patient. So in the case scenario that we mentioned, it's important to know if the individual traveled to Nigeria secondary to the diphtheria outbreak, or if they went to Mexico and had surgery, not just that they traveled outside of the country. And additionally, there was a letter to the editor that was done in the Journal of Emergency Medicine that noted that it's difficult to identify and isolate individuals with illnesses such as influenza and TB, making quick identification of emerging pathogens more daunting. And so, we have these patients, they come in, again, they have non-specific symptoms, respiratory illness, for example, and I can recall at the beginning of the COVID pandemic, where the recommendation was to isolate people that came in that had respiratory symptoms. And wow, isn't that a challenge when it's the middle of respiratory season? And so really the recommendation is to screen everyone. So universal screening based on what is the history of their present illness? What is the symptoms? What is the date of symptom onset? Where was the individual when they became ill? And did they seek or have healthcare while they were abroad? And then what are those travel details that they had? So I come to the emergency department or a primary care provider. I have an acute illness. Next question is, what are your symptoms and have you traveled? And the question's really around, where did you go? Why did you go? Did you go for business? Did you go for humanitarian aid? Did you go to vacation? Were you visiting friends? Where did you stay? Did they stay in a hotel? Did they stay in a hostel? Did they go camping? Did they stay at an individual's home? What recreational activities were done? Did they go on a safari? Did they go on a boating or a rafting excursion? What exposures did they potentially have? Did they consume raw meat or unpasteurized dairy? Again, did they seek medical care there, or did they receive any tattoos or piercings while traveling? And then the question being, what precautions did they take? Did they take malaria prophylaxis? Was that available to them? Did they receive that? Did they receive the vaccines that were recommended for traveling to the location that they traveled to? And did they utilize things such as mosquito nets or other preventative measures, depending upon the location that they went? The challenge becomes there's a lot of travel associated illnesses that one could argue are illnesses that we see here. So for example, influenza. Influenza may not be something that we would consider to be a potential challenge as it relates to travel, unless someone comes back from a country in the middle of the summer, a time that we traditionally in the United States do not have influenza, and that individual does have influenza, right? There's a high probability that individuals would not be vaccinated against influenza. And so that could potentially become a challenge for us in the healthcare setting if we have somebody with influenza that comes back in the middle of the summer. This is just here not as we need to remember and memorize all of the potential travel associated illnesses, but just as an idea that most of those illnesses, again, occur within 30 days or within a month of return from their destination. So the question becomes, how do you do a travel screen? So if we know why we need to do a travel screen, we understand the case scenarios or the case definitions of what that travel screen should actually look like. The next question becomes, how do I actually do this screen? And so there's a document that's been developed through Impact Project First Line at Massachusetts through Neotech, and is actually used through Massachusetts General as well, that has developed what you would really an algorithmic based process. And it starts out with individuals that are not clinical can perform some of these travel screen questions. The first start is with symptoms. Are you symptomatic? Do you have a fever? Do you have a cough? Do you have a new rash? If the individual answers yes to those, then automatically starting with source control. And I think that prior to the pandemic, source control might not have been something that people were entirely familiar with. But if we're going to have a win from the pandemic, it's that source control can really help prevent the spread of infections. And so providing that individual with a mask, regardless of whether or not they have traveled outside of the United States or traveled at all, to inhibit them from spreading that illness to anyone else. The next thing is to actually ask those travel questions. Have you traveled outside of the United States? Have you had contact with somebody who is ill and has traveled outside of the United States? You'll notice within this algorithm, if the answer is no to travel outside of the United States, then you go to the next question, and it'll tell you where to go. So do I go to number 3? Do I go to number 4? Specifically around, have you been in contact with somebody who has traveled outside of the United States in the last month? And if so, has that person been ill? And so it is not incredibly uncommon for individuals to have traveled outside of the United States, have contact with their family members or friends, they are ill, and then subsequent people in the family become ill, even though they themselves may not have traveled. One additional, as it relates to this algorithm, is the option to add in the have you traveled to a certain location within the United States. And so this is very interesting to me and pertinent in the setting of some of those measles outbreak. So we know that we had a case of measles in an individual who went to a large group gathering and had the potential for a number of peoples to become exposed to measles during that scenario. And while those people may not have traveled outside of the United States, there was a specific location within the US, actually within the state of Kentucky, that we could ask that specific question to see if they had been there. And so in this scenario, the example is, have you been to a certain theme park? There have been measles that has been identified in people that have gone to places like Disneyland or other high travel, large populous people going and potentially exposing other people. So that is only pertinent when those outbreaks are occurring within the United States, but it's interestingly something that can be added as part of that travel screen process. And then you'll notice that once you get to 6 or above, that's really when the clinician needs to come in. So those other questions, those beginning questions of have you traveled outside of the United States? Where did you go? Have you been in contact with somebody that is ill? Does not have to necessarily be clinician focused, but it does need to be clinician focused once you get to the point of, yes, I have traveled, yes, I am sick, and yes, there is a concern that there could be an outbreak in the location that I traveled to, and there is something that needs to potentially be done in that scenario. It goes on to really get into and dig more into that travel assessment process. So what isolation is needed? Is there any EpiLink that needs to be gathered and understood? And this is relatively important, particularly in the scenario that you have to get approval from external groups, the state, the CDC, to be able to send those labs, and what makes a patient a person under investigation for a specific illness. Additionally, it allows for understanding of, is this person really a person under investigation or not? And so it is not always just because I traveled that I am always a PUI. There may be some other reason for this illness that's much more plausible, and I really didn't go to the place that the outbreak was occurring, or that this pathogen is common in. So the idea of a travel screen and what to do and how to create a travel screen, I think most electronic medical records have that. The question becomes really around operational issues. And so standardized procedures, facilities really need to have that standardized procedure for what you are going to do when an individual screens positive. Immediately isolating the patient, clear communication of their procedures, and understanding and doing a further evaluation to determine if the individual is a PUI or not, for the illness that's circulating in the location that they traveled, first understanding where they traveled and an illness associated with that location. And so that's really important as it relates to, is everybody a PUI? Well, maybe not. Right? So if I come in and I've got signs and symptoms for diphtheria, I might be a person under investigation for diphtheria, but I may also have traveled and had a travel associated illness such as traveler's diarrhea. So thinking traveler's diarrhea versus an outbreak of cholera. Do they need testing? What is that, the case definition, and how quickly can we screen low risk positives? So having that clear case definition, some institutions have utilized their electronic medical record really as a way to understand what is occurring outside of the US. So some systems allow for inputting a country into the electronic medical record, and illnesses of concern auto-populate. So it'll tell you what illnesses are currently in outbreaks, what illnesses are currently circulating within that community or in that country. This is not a process that all institutions have. Not all institutions are able to utilize their electronic medical record in that capacity. And other processes become relatively time consuming. The question becomes, do providers have to look individually up each country that an individual has traveled to identify illnesses of concern? And can they do that? Is that something that is in the ability of their current workflow? Absolutely, they can go to the CDC site. You can go to the travel page, and drop down list is available that shows countries that individuals can click on and see what is occurring. But operationally, is that something that can absolutely be done? Efficient diagnosis. Do they know they need to test? Do we know what we need to test for, right? So what is the illnesses that we are suspecting? What are the appropriate tests for those illnesses? And what's the quickest way to get the results, right? And so I take us back to the beginning of the COVID pandemic, where there were individuals that came in and we had to be very selective on who we were going to test. Who is a person that we are putting as a PUI and has a test going to the state? How long is it going to take to get those results back? And what do we do with these other people that are showing signs or symptoms and until we are able to get a more rapidly available testing algorithm back? The other thing is looking at the symptoms that they've got, and can we downgrade the isolation that the patients are in? Because not all travel histories are the same, right? So the individual in the case, the hypothetical case scenario, they came in with a fungal infection. Absolutely, that fungal infection, understanding that that individual had traveled to Mexico and received a surgical procedure in the city that is currently experiencing that fungal outbreak, is very important as it relates to the care of that patient. But that probably, from an infection prevention perspective, isn't going to impact other patients in their immediate surroundings or change the personal protective equipment that is needed. That wouldn't so much be the case for a viral hemorrhagic or a measles case that an individual may show up to in your emergency department or someplace else. Understanding what tests you need to get absolutely is going to understand the diagnosis, and then do you need to do case investigation or epilinks? One example would be for measles, right? Do you send a measles PCR to the state or a measles IgM? What tests can be done in the lab versus what needs to be sent out to the state or reference labs? And then how are you going to provide care for these patients once while you are waiting? So if you're waiting for your viral hemorrhagic fever testing to be completed, right, you're not doing that in your micro department at your facility. How are you going to provide care to these individuals? And so that really focuses on the streamlined PPE guidelines. What kind of guidelines or what kind of PPE do we need to wear? And how do we wear it and provide care? How do we get it on? And how do we get it off? And so the question around, do we need to do a travel screen, I think is a relatively easy question. Yes, we should do a travel screen. We should do a universal travel screen on individuals who present with an acute illness, so that we can understand the expansion of their differential diagnosis and get the treatment that they need, and prevent the potential for the spread of that illness to other people's within our community. And so doing a travel screen is very important. The operational questions of how do I, once I have started this travel screen, how do I promptly isolate, identify, diagnose, and protect my employees and staff and other patients, become the operational questions that become a challenge in performing travel screens in many facilities, both acute care and otherwise. Any questions for me?
All right. I just want to thank Dr. Frith for this wonderful presentation and invite everybody back next week to join us. Thanks so much for joining this afternoon, and see you